Please start out of
Yeah, so good evening, everybody, and thank you all for joining in for the evening session. And today we have our eminent speaker, Dr. Pooja Tyagi, who's based out of Medanta, Gurugram, and she's taking a session on the pharmacology and the PKPD of various drugs, which we use very commonly in our liver critical care and gastro liver ICUs. So this would be a good refresher session, and should be taking the latest. Should be talking about the latest evidences uh, with regard to wherein the drug fits into the present use. So over to Dr. Pooja for the interesting session.
Yeah, thank you. Thank you so much, Dr. Munish, for the introduction. A very good evening, everyone. This is Dr. Pooja Tyagi here. And as Dr. Munish said, I'll be talking about the clinical pharmacology of the drugs which are relevant to us when we are dealing with our patients who present with gastrointestinal diseases or liver disorders. And there's a long list of drugs that are there when you're managing such patients. But then I'll try to focus and emphasize on the important ones, the most relevant ones. So with this, I think we'll start. Clinical pharmacology of the drugs relevant to us when managing patients with gastrointestinal and liver diseases. So the drug list that I would be covering today would be mainly the N-acetylcysteine, the vasoactive drugs, which are terlipressin, octreotide, and midodrine. And we should be talking about albumin, the common ones that we use every day maybe, proton pump inhibitors, the sucralfate, lactulose, rifaximin, and few drugs that are being used in the management of Clostridium difficile infection. So starting with N-acetylcysteine, it is an acetylated analog of endogenous semi-essential amino acid cysteine. And it is a very common drug that is being used. And again, along with that is an over-the-counter drug that is, it is so commonly available. But then it has a very varied action that is there and very important action that are attributed to it. It is majorly an antioxidant. So it has direct and indirect antioxidant actions. And besides that, it also acts as an anti-inflammatory agent. And in addition to that, it has certain mucolytic properties also. So coming to the direct antioxidant actions, in certain conditions, the NAC, as it is popularly called as, can act as a direct antioxidant for certain oxidant species, such as maybe nitrous dioxide and hypohalous acid. So in that, it acts as a chelating action. It has a chelating action where it is capable of binding transition metal ions and heavy metal ions, forms complexes, and these complexes are eventually excreted from the body. So this is a direct antioxidant action that is attributed to NAC. So in addition to this, it also has certain indirect action, wherein it restores or increases the pool of intracellular cysteine, which is actually the building block and limiting step in the rate of synthesis of glutathione. So glutathione is a major antioxidant that is present in human body. It regulates intracellular and extracellular oxidative metabolism, inflammatory processes, and influences many cellular regulatory functions. So NAC is able to restore these systemic pools of small thiols and reduce proteins sulfhydryl groups, so which are involved in the regulation of the redox state. So in that way, by replenishing the stores of cysteine and eventually that leading to formation of glutathione, it has an indirect antioxidant action. So besides the antioxidant action, it has certain anti-inflammatory action also. So NAC suppresses nuclear factor kappa B activation, which in turn decreases the levels of pro-inflammatory mediators such as TNF alpha, the interleukin 1 and 6. So all this has an anti-inflammatory action. So the fourth property that is being attributed to NAC or has an action on, it has a mucolytic action. So wherein the NAC, it leads to breaking off of the disulfide bridges that are there in the high molecular weight glycoprotein in the mucus. So this eventually leads to a thinning of the mucus, the reduced viscosity. So in turn leading to a mucolytic action. So these are the varied ways in which NAC can be used. And the major routes through which it can be administered. So it can be given as an oral tablet form, or it can be used as intravenous infusions over extended hours when it is diluted with crystalloids and then administered, or it can be used as an inhalation agent for its mucolytic property. So these are the actions of NAC. So since NAC is just an N-acetylcysteine, and we get to know cysteine is the building block, which is eventually leading to formation of glutathione in the body. So why not just give cysteine? So the difference here would be when cysteine is provided, whether exogenously or it is present in high amount, there's a faster uptake of cysteine that happens inside the cell. So fast uptake would lead to a larger amount of cysteine that's get accumulated inside the cell, and this cysteine, which eventually will form hydrogen sulfide and sulfane sulfurs in larger amount. So large amount of cysteine leading to large amount of formation of hydrogen sulfide and sulfane sulfur. So this large amount of these hydrogen sulfide leads to overwhelming of the electron transport chain, eventually leading to its blockage and non-functional, making it non-functional. So it interferes with the metal centers also in addition to that. So all these will lead to a cytotoxic state and eventually cell death. And when you use NAC for providing cysteine, so there's a slow delivery of cysteine that happens inside the cell. The slow and regulated amount of or delivery of cysteine that is there inside the cells would lead to a regulated amount of hydrogen sulfide and sulfane sulfur getting produced inside the cells. So this eventually will lead to a stimulation of mitochondrial bioenergetics, modulation of certain protein functions, protection against irreversible oxidative damage, and increase of oxidant scavenging capacity. So all these in total will have cytoprotective effect and will actually be a form of as an antioxidant action. So this is why it is important. Now, cysteine is provided as N-acetylcysteine and not just as pure cysteine. So coming to pharmacokinetics of NAC. So time taken to reach maximum blood concentration when it is used through nebulizers as inhalation would be 1 to 2 hours, and oral administration would take around again 2 hours to reach maximum blood concentration. And coming to plasma protein binding, the NAC, it is a range which is from 66 to 87%. NAC gets metabolized to disulfide, cysteine, and various conjugates. Elimination, the terminal half-life of NAC after an IV single dose is around 5.6 hours, and 30% of NAC is cleared or eliminated through the kidneys. So role of NAC in acetaminophen-related liver injury. So paracetamol per se is metabolized when it is ingested through glucuronide conjugates and sulfate conjugates, and a certain amount of NAPQI is formed through CYP450 enzyme system. But when there is a supratherapeutic dose or a poisoning that is happening, when there is large amount of acetaminophen that has been taken by the patient or person, a large amount of NAPQI would be formed. So this NAPQI is usually inactivated by presence of glutathione. But then when you have a large amount of NAPQI that is getting formed, like that happens in acetaminophen poisoning, your glutathione stores will get overwhelmed. And eventually this NAPQI will lead to bind to your hepatic cellular proteins and eventually lead to hepatocellular necrosis. So herein there is a role of NAC that is there. NAC which provides a cysteine and leads to formation of glutathione. So if glutathione stores are replenished, which metabolizes or inactivates your NAPQI, leading to paracetamol glutathione conjugates, and eventually cysteine and mercaptopuric acid conjugates are formed. So this is how NAC works in preventing liver injury, which is related to acetaminophen overingestion. So coming to its role in non-acetaminophen liver injury, whether it is seen with mushroom poisoning or acute viral hepatitis or a drug-induced liver injury and pregnancy-related liver injury, all that will lead to oxidative stress or increase in the pro-inflammatory markers, the cytokines, and eventually leading to a direct liver injury, systemic inflammation, decreased organ perfusion and oxygen delivery, and eventually organ dysfunction. So NAC, here again, acting as a source of cysteine, increasing your glutathione levels, it actually decreases the oxidative stress and decreases the pro-inflammatory cytokine levels. So this is how it works in a non-acetaminophen liver injury and is protected. So these are the clinical practice guidelines given by the one on the left by the European Association for the Study of the Liver. They said drug-induced liver injury, especially talking about paracetamol toxicity here, which is the most frequent cause of severe acute liver injury and eventually maybe acute liver failure. So these patients who have coagulopathy and increased serum transaminases, N-acetylcysteine therapy should be given. For this, they gave the recommendation grade that they gave was 1 and level of evidence is 2. This was by the European Society. The one on the right, this practice guidelines were given by American Association who study liver disease. And with regard to drug-induced liver injury, they said intravenous or orally administered NAC can prevent liver injury nearly completely if given within 12 hours of ingestion. But then it is also recommended recommended for patients who come beyond 12 hours of ingestion as well. So the dose provided here or mentioned the guidelines are they have given both oral doses and intravenous doses. So patient who can tolerate the oral dose that is being given, it is administered as 140 milligram per kg as the loading dose and is followed by 70 milligram per kg every 4th hour. And with this dose, usually the antiemetics are needed. But then if the patient is non-tolerant or is not able to take orally, an IV administration can be given, wherein the total of 300 milligram per kg of dose is given over 24 hours. So acetylcysteine is usually administered, the infusion of the same is administered in a 2-stage form or 2 bags that are being prepared. So a total of 300 milligram per kg of dose is being administered in 24 hours. So first bag contains 200 milligram per kg over 4 hours diluted in crystalloid solution, and it is a solution can go up to 500 ml maybe and given as an IV infusion over 4 hours. So at the end of 4 hours, the second bag is prepared, which contains 100 milligram per kg of N-acetylcysteine, and this solution is administered over the next 16 months. And patients who come with massive paracetamol exposures, we can double the dose of acetylcysteine in the second acetylcysteine infusion bag that we prepare. If at all, the paracetamol concentration is more than 2 times on the nomogram. And all these weight-based dose that are being administered of the acetylcysteine, it is actually calculated based on actual body weight. So if a patient weighs more than 110 kgs, we calculate the dose based on 110 kg of body weight. So coming to side effects, easily available over the counter, but then this is again one drug which is not free of side effects. So acetylcysteine can be associated with gastrointestinal upset. It can lead to nausea, vomiting, abdominal pain, and diarrhea. And then it can have certain non-immunologic anaphylaxis reaction, wherein the patient can present with flushing, rash, itch, wheeze, shortness of breath, and hypotension. So in these cases, we stop the infusion, we can give promethazine, and we can restart the infusion at the end of or after 30 minutes at half the previous rate. And we can slowly go on increasing the infusion to the full rate over next 30 minutes maybe. So patients who have had previous non-IgE mediated anaphylactic reaction, it does not preclude the use of NAC in future if it is needed. So in this slide, we see the various intravenous NAC regimes that have been evaluated in different randomized controlled trial. So the topmost is the conventional regime, wherein they have given a 300 milligram per kg of NAC in a duration of 20-21 hours. They have prepared 3 bags here. So the loading dose was given as 150 milligram per kg over 15 minutes diluted in a crystalloid solution. So at the end of this loading dose, the next dose prepared was, or the next bag that was prepared is 50 milligram per kg, which was administered over a period of 4 hours. And at the end of 4 hours, a third bag was prepared with a dose of 100 milligram per kg of NAC, and this solution was administered over a period of 16 hours. So this is the conventional regime of giving a NAC infusion. And at the end of 20 hours, we do a blood test and we discontinue NAC at the end of when the third bag finishes if the INR is less than equal to 1.3, the ALT levels are less than 100 units per liter. There is no further doubling of ALT levels. So this is the conventional regimen. Then came the SNAP and the SAPO regimen. SNAP and SAPO has similarity wherein they restricted the duration of NAC therapy for initial to 12 hours. Rather than giving over 20 hours, they were giving in 12 hours. Again, there was some difference in the dose that was being administered. So in the SNAP regimen, the loading dose that they gave was 100 milligram per kg and in a diluted form, and it was given over a period of 2 hours. While the conventional regime, wherein the loading dose was given in the initial 15 minutes, that loading dose slightly reduced was given over a period of 2 hours. And the remaining 200 milligram in a diluted form were given over the next 10 hours. So at the end of 10 hours, they did their blood test and they discontinued NAC if after finishing the second bag, the paracetamol concentrations were less than 20 milligram per liter, the INR was less than equal to 1.3, the ALT levels were less than 100 units per liter, and there was no doubling of ALT levels further. So this was the SNAP regimen. The third one, the SARPO regimen, therein they reduced the total amount of NAC that was being administered. So in the initial above two, there were 300 milligrams per kg they were giving. In this, they were giving 250 milligram per kg. That was the total dose that was administered. So a loading dose of 200 milligram per kg given over a period of 4 hours, and then a 50 milligram per kg which was administered over next 8 hours. So blood test done at the end of 12 hours and the NAC was discontinued if the ALT levels were less than equal to 50 and there was no further doubling of ALT levels. So these are the 3 regimes which are there, and a little more about them. So the key difference between the conventional and the SNAP regime was conventional, which was given in 24 hours time using 3 bags, the SNAP, which were given the same dose of NAC, which was given over a 12-hour period using 2 bags. So the important difference here was the side effects or the anaphylactoid reactions were much, much lesser with the SNAP regimen than with the conventional. So when you have lesser any side effect which is lesser, obviously the tolerability, the acceptance is more. However, the efficacy was equal between the conventional and the SNAP regimen. The hospital stay was found to be shorter with the patients who received the SNAP regimen, and they advocated the SNAP regimen to be best for offered to people or patients who came with early presentation, who came with less than 8 hours of ingestion of the toxin. While the SAPO trial, it was a non-inferiority randomized controlled trial of shorter duration. So a shorter duration, 12 hours NAC infusion, which was as effective as standard conventional 24-hour regimen. But then it was done wherein the paracetamol overdoses was less than 30 grams that was ingested. So this short regime was safe with similar or lesser side effects maybe. And in compared to the conventional regime, the regime total duration of the regime was shortened to 12 hours. So this was about the SAPO trial. So next, coming on to the vasoactive drugs that are relevant and important to us when we are dealing patients with GI disorders or liver diseases. So you have important ones that are there and that we'll get to know in detail would be somatostatin and its analog, which is the octreotide, vasopressin and its analog, terlipressin and midodrine. So terlipressin. So route of administration, therein we can administer terlipressin would be an intravenous injection or an intramuscular or you can give it as a subcutaneous injection. It has a poor oral bioavailability of less than 1%, good water solubility, a minimally protein-bound drug. So terlipressin and its active metabolite, they have about 6 times more affinity for V1 vasopressin receptors that is there on the vasculature, leading to a vasoconstrictor effect as compared to V2 receptors, which are seen in the collecting tubules of the nephron, exerting an antidiuretic effect. So it is mostly metabolized into lysine vasopressin by endothelial peptidases. It is almost completely metabolized. The lysine vasopressin is eliminated further by hepatic and renal clearance. The half-life of terlipressin is about 50 minutes. But because the daughter molecule is an active drug, the duration extends up to maybe 6 hours. So the vasopressor effect or the vasoconstrictor effect is usually exerted through the V1 receptors which are there on the vasculature. So these are GQ coupled receptors, and they increase the intercellular calcium by increasing the cyclic AMP concentrations, while the V2 receptors, they are GS coupled and they produce the insertion of aquaporins into the apical membrane of principal cells of collecting tubules. So overall clinical effect would be a vasoconstriction. There is redistribution of splanchnic blood flow and a modest antidiuretic effect. So on the splanchnic circulation, it will lead to a decreased mesenteric blood flow and hence resulting in a decreased portal venous pressure, which is desired when you want to control or manage your variceal bleed in the treatment of hepatorenal syndrome. So while exerting this vasoconstrictor effect, it can actually worsen your coronary ischemia and lead to a diastolic dysfunction. So coming to hemodynamic and neurohormonal effects of terlipressin. So as we know, it has a vasoconstrictor effect on the vasculature. So hence it increases the systemic vascular resistance, it increases the mean arterial pressure. While it reduces diverting the blood flow from the splanchnic circulation, causing a splanchnic vasoconstriction, it also reduces your portal pressures, reducing the portal blood flow and further reducing the hepatic vein pressure gradient. In the kidneys, it actually increases the renal perfusion, causing natriuresis, diuresis, and thus reduce RAS activation. At the level of the brain, it reduces the sympathetic nervous system activation and further reduces the vasopressin release. So practice guidelines for use of terlipressin in liver cirrhosis related complications. This was published in 2022 in Therapeutic Advances in Gastroenterology. So the key statements here were, while managing your variceal bleed, terlipressin is recommended for the treatment of gastroesophageal variceal bleed in liver cirrhotics. The other statement that they gave were, should be considered for management of acute GI bleed in patients with liver cirrhosis before endoscopy, and if gastroesophageal variceal rupture is suspected as the major source of bleeding. So terlipressin may be preferred in cirrhotics with acute GI bleed and those who come with renal dysfunction also. With regard to hepatorenal syndrome, it is recommended for treatment of type 1 hepatorenal syndrome in liver cirrhotics. With regard to ascites, the statement was it was considered for severe or refractory ascites in cirrhotic patients. If diuretics are ineffective or a patient cannot tolerate diuretic-related adverse effects. So in patients, cirrhotic patients who undergo large volume paracentesis, when we are removing more than maybe 5 liters of free fluid from the abdominal cavity, can lead to a post-paracentesis circulatory dysfunction. So prevention of these can be done, and wherein you're planning such large volume removal of fluid, terlipressin should be considered. With regard to bacterial infection, they said it should be considered in cirrhotics with bacterial infection to improve systemic hemodynamic status, the microcirculation, and organ perfusion. In hepatic resection and liver patient undergoing liver transplant, the terlipressin can decrease intraoperative portal pressure, decrease the overall blood loss and amount of blood that needs to be transfused, and also improve overall systemic hemodynamic status and renal function in these patients. So what are the recommended doses of terlipressin in acute variceal pain? So both American Association and European Society, they have advocated an initial dose of 2 milligram of IV terlipressin given as a bolus and repeated every 4 to 6 hours for first 24 to 48 hours. And the maintenance dose is given as 1 milligram bolus every 4 to 6 hours. And the total duration of therapy would be from 2 to 5 days. So this was an article published in 2022 wherein they studied safety, tolerability, and pharmacokinetics and efficacy of terlipressin, whether it was given by continuous IV infusion in patients, cirrhotic patients with refractory ascites. So the table here shows the spikes when you give your bolus doses as maybe 4th hourly or 6th hourly terlipressin is given as an IV bolus. We see the peak, the plasma peak that we see whenever the bolus is administered. And after a certain time, the peak falls down to the baseline, basically. So this is how the bolus doses work. This is intermittent, the spike every time, and the levels coming down after a certain amount of time period. So whenever terlipressin is given as an IV infusion, there's some steady state that is achieved, whether you give it as a 2 milligram in 24 hours or a 3 milligram over 24 hours or any other strength that you're using. So you'll have a steady state concentration, blood concentration that is achieved when you give a continuous IV infusion of terlipressin. So it was studied superior hemodynamics could be achieved when you're using as a terlipressin as a continuous infusion. There were greater reduction seen in hepatic vein pressure gradient in continuous use of terlipressin, and there were lesser side effects with continuous infusion, and they were better tolerated. So terlipressin in hepatorenal syndrome, the European Society gives guideline over this. They say the terlipressin should be given as a 1 milligram bolus dose every 4 to 6 hours when you're using it as a boluses maybe, or a 2 milligram in 24 hours infusion can be administered along with albumin, which was given in a dose of 20 to 40 gram per day in 24 hours time. And you repeat your serum creatinine at the end of day 4. So if there is more than 25% decrease from the baseline, we continue at the same dose for this patient. You treat until you get a complete response, wherein maybe your serum creatinine is less than 0.3 milligram per deciliter, or you have given the therapy for maybe a maximum of 14 days. If at all you do not achieve this decrease in the baseline of creatinine, maybe it is less than 25% decrease that you get, you can increase your dose of terlipressin in a stepwise manner, maybe in a 2 milligram per day manner, and you can go up to 12 milligram per day. Again, try to achieve a complete response, achieving maybe a serum creatinine of less than 0.3 milligram per deciliter, or giving it for maximum of 14 days. So confirmed trial was one trial wherein they were studying terlipressin with placebo and managing type 1 hepatorenal syndrome. And they stated almost the same what was there in the European Society of Guidelines. It was just that when they're looking at serum creatinine at day 4, the decrease they mentioned was, or studied was more than 30% decrease in the creatinine baseline. So coming to adverse effects of terlipressin. So there are various adverse effects that can be there, and then there are risk factors which can actually lead to these effects. And then you have some protective mechanism or mitigating factors that can be employed when you face such adverse effects. So pertaining to gastrointestinal side effects that are there with terlipressin, you can actually reduce the dose or maybe temporarily stop or take a pause in the treatment and then restart maybe. Or you can also switch to a continuous infusion form of administering your terlipressin rather than a bolus dose that you're using maybe. So coming to the respiratory failure, the risk factors being if the patient already has some advanced hepatorenal syndrome, acute kidney injury, or it is an oliguric renal failure, or there is excess albumin replacement that has the patient received. A patient is already a cardiac failure candidate or have some cardiac diseases maybe. So mitigating or protective factors here would be starting early initiation of treatment, regular fluid balance assessment that needs to be done, judicious personalized administration of albumin based on volume status assessment that we do. And we avoid giving terlipressin in patients who are in NYHA class 3 or 4 of cardiac failure. So coming to hyponatremia, so risk factors being when you have a higher serum sodium, when you're starting a therapy with terlipressin, patient already has a higher serum sodium, or a low serum creatinine, a lower child poop or MELD score, and whenever there's a rapid change in the fluid status. So you monitor your serum sodium regularly. That can be one way of keeping a track of sodium, and you have active titrations of diuretics with treatment response, and switch over to a continuous form of administration your terlipressin rather than give it as a bolus dose. The last one would be an organ ischemia. So risk factors being whenever there's hypovolemia, and then you start with the therapy of terlipressin, the patient already has atherosclerotic risk factors in form of smoking and diabetes. There's underlying severe coronary artery disease, or maybe a severe peripheral vascular disease, or with concomitant use of vasopressors that the patient requires maybe. So we should ensure the volume is replete, adequate, or maybe in euvolemia prior to commencing terlipressin. And we avoid use of terlipressin in severe coronary artery disease, and altogether avoid it in severe peripheral vascular disease also. And you can switch over to a continuous mode of giving your terlipressin over bolus dose. That can also be done. So coming to octreotide, which is a somatostatin analog, can be given as an intravenous or a subcutaneous form of administration. And when it is given as a subcutaneous form, it is rapidly, completely absorbed. And with peak plasma in 30 minutes, that levels achieved. Protein binding is around 65%, 30-40% is metabolized by the liver, and 1/3 is excreted unchanged in urine. So half-life in normal healthy individuals would be around 1.8 hours. And in renal and hepatic dysfunction, it gets prolonged. So its mechanism of action, it is an octapeptide. It mimics the action of somatostatin, suppresses endogenous insulin and glucagon secretions. And this might just be useful in treatment of sulfonylurea toxicity. It reduces the splanchnic blood flow and portal venous pressure. So on-label use of octreotide would be a variceal bleed, wherein it causes vasoconstriction and reduction in portal venous pressures, and also the gastrointestinal neuroendocrine tumors for symptom management for reducing hormone secretion. So these are the two on-label use. The others are off-label use, which wherein it can be used in colorectal cancer, the dumping syndrome, refractory diarrheas, angiodysplasias. So the dose of somatostatin and octreotide in while managing your variceal bleed or prevention of early rebleed. So octreotide, it is given as a IV after a 50 microgram IV bolus. It is given as a continuous IV infusion at the rate of 50 microgram per hour. And you can give additional IV boluses if at all there is ongoing bleed that is there. The duration of therapy can range from 2 to 5 days. Somatostatin, it is given as a bolus dose of 250 microgram, followed by a continuous infusion, which the rate can vary from 250 to 500 microgram per hour. And additional IV boluses can be given if there is evidence of ongoing bleed. Again, the duration of therapy is from 2 to 5 days. So coming to adverse effect, so octreotide, the common adverse effect would be, which are reported in more than 10% of patients, maybe a bradycardia, a cardiac conduction abnormalities, diarrhea, nausea, abdominal discomfort, and rarely reported would be arrhythmia, a severe epigastric pain, dizziness, headache, fatigue. Somatostatin, on the other hand, commonly mentioned adverse effect would be a diarrhea, abdominal pain, nausea. Lesser known would be constipation, arthalgia, and headache. So, 2008, a randomized controlled trial where they studied terlipressin versus octreotide in bleeding esophageal varix as an adjunct to therapy, wherein the primary therapy was endoscopic band ligation. And they concluded the efficacy of terlipressin was not inferior to octreotide as an inject therapy for control of esophageal variceal bleed and in in-hospital survival. So they were equally effective. The other RCT done in 2014, starting lack of difference among terlipressin, somatostatin, and octreotide in the control of acute gastroesophageal variceal hemorrhage, and they concluded the hemostatic effects and safety did not differ significantly between the three drugs as adjunct to endoscopic management of these patients. So coming to next drug, next vasoactive agent, which is midodrine. The route of administration, it is given as an oral tab form. It has good oral bioavailability of 93%, good water solubility. Less than 30% of it is protein bound. It is a prodrug. So it is metabolized in liver, and the active form is desglycomidodrine, and this in turn is metabolized by hepatic oxidation. So minimal free drug is eliminated in urine. Half-life, the prodrug is 30 minutes. However, the half-life of the active component, the desglycomidodrine, is about 3 hours. So it is an agonist of alpha-1 receptors. It acts similar to noradrenaline. It increases the release of secondary messengers, the inositol triphosphate, which results in the release of calcium into the cytosol, thus enhancing the smooth muscle contractility. So apart from increasing a peripheral resistance and blood pressure, it can cause piloerection, diarrhea, and urinary hesitancy. So comparing the various vasoactive medication, the terlipressin, NORAD, midodrine, octreotide, and vasopressin. So FDA approved to treat hepatorenal syndrome with which results in rapid reduction in kidney dysfunction. They said terlipressin was the primary agent which could do this and was the preferred drug. Also, the American Association of Studied Liver Disease in the management of hepatorenal syndrome. The first preference was terlipressin, followed by NORAD, and midodrine was the third preference. And for efficacy and safety for treating HRS, terlipressin is again a yes from FDA approved. And terlipressin can be used both in the ICU setting or the medical flows. While norepinephrine, vasopressin, of course, is being used and has to be used in the ICUs. Mechanism of action, we are all through with this. Acts on the V1 receptors on the vasculature, leading to a vasoconstrictor effect, and targeting the splanchnic circulation, decreasing the portal venous pressures. NORAD, it's a mix of alpha-beta adrenergic receptors, acts on the peripheral vasoconstrictor in setting of hepatorenal syndrome. Midodrine, alpha-1 agonist that acts as peripheral vasoconstrictor, while octreotide, it's an analog of somatostatin, reduces the splanchnic blood flow. Vasopressin causes vasoconstriction by obviously binding to the vasopressor or V1 receptors on vascular smooth muscles. So coming to albumin, albumin is primarily an intravascular molecule, and it has a huge contribution to the oncotic pressure of the intravascular system. So it is the predominant protein in the intravascular space, accounting for 75 to 80% of your intravascular oncotic pressure. And it has a strong molecular negative charge, thus resulting in binding to a wide array of molecules, the positively charged, the cations, and it exerts some antioxidant property wherein it binds to a number of metal ions, preventing them from catalyzing various reactions which can lead to formation of free radicals. As an anticoagulant, it inhibits the platelet aggregation for platelet plug formation and heparin-like neutralization of factor 10A by antithrombin 3. It stabilizes the endothelial layer and maintains the normal capillary permeability. This is another important physiological role the albumin plays. So it's a mediator of inflammatory response and reduction of oxidative damage. So it also has a role in binding to wide range of molecules and leading transport of various molecules, including metals, gases, endogenous molecules like cholesterol, fatty acids, bilirubin, or exogenous substances such as toxins and drugs. So albumin in healthy individual, so it is the most abundant circulatory protein, constituting of 50 to 60% of the total protein, but it has certain oncotic and non-oncotic properties. So oncotic is regulation of fluid distribution, it is because of the net negative charge. It has a high molecular weight and high plasma concentration. Then it has certain non-oncotic properties. So that is because of maybe binding, transport, and detoxification of many endogenous and exogenous compounds, including drugs. It leads to free radical metal ion scavenging, acting as an antioxidant, endothelial stabilizing effect, and has role in immune inflammatory response modulation. But then what happens to albumin in a patient who has decompensated cirrhosis? So besides reduction in the plasma concentration of the albumin, because of reduced synthesis or increased catabolism, there's also a structural damage of the albumin. So there's reversible and irreversible oxidation and glycation that is happening. So reduced plasma concentration, in addition to that, there's the structural damage of the albumin. So there's impaired function, impaired non-oncotic function as well. So there's reduced antioxidant activity, there's reduced binding, detoxification qualities, and probably a reduced anti-inflammatory activity as well. This is how albumin gets affected in a patient with decompensated cirrhosis. So current recommendations for administration of albumin as per European and American Association who studies liver diseases. The current recommendations are whenever you're doing a large volume paracentesis, you're removing more than 5 liters of free fluid in a day's time, or a patient with acute kidney injury or a hepatorenal syndrome and spontaneous bacterial peritonitis. So these are on class 1 current recommendations for administration of albumin in cirrhotics. But then there are some potential indications wherein you can give administer albumin to the patient who has cirrhosis. So when you're doing a modest volume paracentesis, maybe in a patient of acute and chronic liver failure, patients who come to us with extraperitoneal infections, long-term albumin administration in cirrhosis with ascites, and you have decompensated cirrhosis with hypoalbuminemia, hepatic encephalopathy, hyponatremia, and a cirrhotic cardiomyopathy. So these are additional potential indications wherein you can use your albumin in cirrhotics. So coming to albumin indications and dosage, in patients of decompensated cirrhosis, you have a disease perspective, and then you're looking at the complications and trying to manage them maybe. So looking at the disease perspective, long-term treatment, wherein you're giving your albumin as a 40 gram twice a week, the first to second week, and then you go up to as 40 gram per week. That's a dose recommended when you're managing your long-term treatment. It is offered to patients who have grade 2 to 3 ascites, maybe a recurrent ascites and a refractory ascites. This is a long-term treatment that goes on for weeks to months maybe. But when you're managing and looking at your complications, trying to prevent them maybe, so whenever you're doing a large volume paracentesis, trying to remove more than 5 liters of fluid, the albumin that needs to be given is around 8 gram of albumin should be given for per liter of ascitic fluid that is getting removed. When you're trying or looking at your spontaneous bacterial peritonitis, the dose recommended is 1.5 gram per kg on day 1 and 2. And then you go in with 1 gram per kg on third day along with antibiotics. Managing your acute kidney injury, which is beyond grade 1B maybe. So the dose recommended is 1 gram per kg for 2 days, a maximum of 100 gram per day, with other measures, of course, managing your renal function, supportive measures. And then in hepatorenal syndrome, there's 1 gram per kg for 2 days, and then 20 to 40 gram per day with terlipressin. So these are the doses of albumin that is advocated in various different conditions. So looking at the long-term albumin treatment that is there, comparing it with the short-term albumin treatment that you aim at. So a short-term albumin treatment, it is usually given up last for maybe 1 or few days or maximum up to 2 weeks maybe. It is usually instituted patients who are hospitalized. The goal is to treat or prevent acute infections. The effect should occur in hours or days maybe. We give high daily doses of albumin are administered with a short time frame. And what you have to watch for is maybe a pulmonary edema. So you assess your patient judiciously, do a repeated serial assessment, fluid assessment, and then maybe administer your albumin. When you're giving a long-term albumin treatment, it usually lasts weeks and months maybe. Given as maybe started initially as hospital and continued in the outpatient at home. The goal is to treat ascites and influence the course of the disease by preventing complications. The effect becomes manifest usually after 1 to 2 months of treatment. So low doses of albumin are infused over a longer time frame. But of course, there are logistic issues associated with it, wherein periodic IV infusion has to be administered at home. So coming to proton pump inhibitor, there's available as IV formulation as well as oral tablets. They're well absorbed in the small intestine. They're deactivated by acids, hence they need an entry coating if they are given through oral capsule forms. So they have first high pass enzyme inhibition. So bioavailability improves after repeated dosing. And they are highly protein bound, 97% protein binding that we get to see. And they are basically inactive prodrugs. They're metabolized by CYP450 in the liver. They get transformed to the active form by the acidic environment of the parietal cells. Minimal renal clearance as unchanged drug. Half-life is 30 minutes to 1 hour. And duration of proton pump inhibition is up to 72 hours because the new protein pump has to be made. So their mechanism of action is they bind covalently to active proton pumps on the luminal surface of the gastric parietal cells. The action of the pump is disrupted, which results in cessation of gastric acid secretion, leads to neutralization of the gastric pH. This neutralization of the gastric pH can lead to various other side effects also, wherein there's hypomagnesemia, affecting the absorption of magnesium, leading to interstitial nephritis, a B12 and iron deficiency, overgrowth of the intestinal bacteria, and then there is risk of C. difficile infection, and also the risk of hospital-acquired pneumonia with neutralization of your gastric pH. So these are the various agents that are there. So pantoprazole, bioavailability 77%, and duration of acid suppression is around 10 to 12 hours. So what are the indications of proton pump inhibitors? They have therapeutic role and prophylactic role. So when you're giving it as a long-term therapy, so definitive indications are the GORD with erosive esophagitis, apeptic stricture, eosinophilic esophagitis, Barrett's esophagus, Zollinger-Ellison syndrome. So these are definitive long-term, wherein you want to give your PPIs for more than 8 weeks. So this is the definitive therapeutic indications. For a shorter course, which is lasting less than 8 weeks, the definitive indications are GORD, the Helicobacter pylori eradication as part of the combination therapy, the non-erosive GORD, the peptic ulcer disease, and mild peptic inflammation. When you're giving as a prophylactic therapy, definitive for long term would be wherein patients are on chronic NSAIDs or aspirin use, and they have high GI risk of bleed maybe. Antiplatelet therapy, post-bleeding ulcer, systemic sclerosis with reflux. And for shorter time, that is less than 8 weeks, as prophylaxis, it will be indicated in NSAID aspirin use, a post-endoscopic ulcer therapy, or a stress ulcer prophylaxis. So besides this, it is recommended as per the gastroenterology clinical guideline use. High-dose proton pump inhibitor therapy is given either as a continuous or intermittently for 3 days after successful endoscopic hemostatic therapy of a bleeding ulcer. This is a strong recommendation, moderate to high quality evidence. So initial management for high-risk bleeding ulcer, the dose that is given is 80 milligram intravenous bolus and a continuous infusion of 8 milligram per hour for next 72 hours. If the patient cannot be given IV in any form, it can be given as an alternative of 80 milligram intravenous bolus and then 40 milligram intravenous twice a day. So post endoscopy or after 72 hours, you can switch to maybe continuous. You can continue your oral proton pump inhibitors given as 40 milligram twice a day therapy for up to 2 weeks total from the index endoscopy that was done. So potential harm that can occur because of long-term use of PPI, so strongly associated with maybe when you give your PPI for a long-term duration, maybe can have Clostridium difficile infection. There can be nutritional deficiencies in terms of hypomagnesemia, iron deficiency, and B12 deficiencies. There can be interstitial nephritis. And there's moderate association wherein there can be osteoporotic fractures because of it. There's issues with calcium absorption. There can be pneumonias, community-acquired pneumonias or hospital-acquired pneumonias. And because of neutralizing of the pH, there can be overgrowth of the small intestine bacteria. And then you have some weaker association, which has been attributed to long-term use of PPI. There can be dementia, a gastric neoplasm, cardiovascular events, and stroke. So coming to next drug, that is Sucralfate. It is a complex salt of aluminum hydroxide and sulfated sucrose. It can be given as an oral preparation, rectal, or a topical application. It is minimally absorbed, insoluble in water. It is not metabolized to any meaningful degree and is eliminated by pieces in over 24 to 48 hours. Duration of action unpredictable, but usually up to taken up as 6 hours. So by dissociating from aluminum, it is a complex salt of aluminum. So by dissociating from aluminum, the sucralfate becomes negatively charged sucrose sulfate molecules, and they bind to anything that is positively charged. So mucus molecule, the cell surface protein, all those are positively charged. They bind to them, they cross-link with these molecules, and they create a protective barrier. So they have the clinical utility in constipation, ileus, and bowel obstruction. Sucralfate has antipeptic effect, wherein it prevents the hydrolysis by preventing enzyme substrate complex formation. This drug absorbs the pepsin and decreases its concentration. And by forming a polyanion gel, it is a physical barrier between the luminal content and the mucosa, protecting also from acid and pepsin. The effect that it has on the mucus, it increases the mucus hydrophobicity, viscosity, sulfation, aluminum carbohydrate content, improving mucosal protection from acids. Additionally, it increases the mucus production by increasing prostaglandin production and prevents the breakdown of mucus by pepsin A. So it is FDA approved as an anti-ulcer drug, and it is being used in duodenal ulcers in a dose of 1 gram 4 times daily for 8 weeks, which is later followed by a 1 gram twice daily dose as maintenance therapy. So off-label use would be dyspepsia, a chemotherapy-induced mucositis, radiation proctitis, and a GERD. It can have several drug interactions. It can decrease the serum concentration of digoxin, levothyroxine, furosemide, quinolones, and other oral phosphate supplements and warfarin. Sucralfate administration should have at least a 2-hour gap from administration of above-mentioned drugs. It has negligible adverse effects, but the one which has been reported is constipation seen in 1 to 10% of patients. Other would be a nausea, vomiting, flatulence, headache, maybe. So coming to lactulose, it is an osmotic laxative. So it usually reaches the colon unchanged and gets broken down to short-chain fatty acids like lactic acid, acetic acid, and the pH of the colon gets decreased. So this acting as an osmotic pressure and a biomass which gets increased. So as a result, the stool volume increases, the feces softens, this creating peristalsis. It reduces the colonic transit time, relieving constipation, has a laxative effect in turn. This is one action of the lactulose. So other would be where the ammonia gets converted to ammonium ions, and also it promotes the growth of saccharolytic bacteria, suppressing the putrefactive bacteria, as a result having a prebiotic effect. So there is uptake of ammonia, there is reduced production of ammonia. So all this will lead to a reduced ammonia content in there, that is there in the colonic lumen and in the blood, and lead to decreased occurrence of hepatic encephalopathy. So this is the detoxifying effect of lactulose. The last would be wherein the solubility of calcium and magnesium salts are improved when you administer lactulose. So this can lead to an enhanced bone health maybe. So overall effect would be a prebiotic effect, a laxative effect, and a detoxifying effect. Clinical benefit that is seen with lactulose is reversing the minimal hepatic or the early grades of hepatic encephalopathy, and preventing the overt hepatic encephalopathy that is there. Increased rate of recovery in overt hepatic encephalopathy, overall improve quality of life, and maybe reduction in mortality. So there are different doses of lactulose which has different clinical effect. When you want to use it as a prebiotic, the low dose would be administered, that is amounting to 15 ml per day or a 10 gram per day of dose. And at this dose, it acts as a prebiotic. When you want to treat constipation maybe or have a laxative effect, you would want to give it in a medium dose. That is 30 to 60 ml per day. That is amounting to 20 to 40 gram per day of lactulose. Then when you want to give it as a detoxifying agent, treating your hepatic encephalopathy, a high dose has to be given, which is more than 90 ml per day or more than 60 gram per day of lactulose that needs to be given. So we have different effective, different doses of lactulose. The side effects can lead to a dose-related diarrhea, nausea, vomiting, hypokalemia if you're not being watchful, abdominal cramps, and potentially it can be fatal if you do not look into the side effects on time maybe. So coming to next drug, which is rifaximin, it is an oral administered gut-directed antibiotic of rifaximin class. And this mechanism of action, it inhibits the DNA-dependent RNA polymerase of the target bacteria, in turn leading to suppression of bacterial RNA synthesis. So it has an antimicrobial effect on the target bacteria. So it also reduces the bacterial attachment, motility, and virulence. It also exerts some eubiotic effect. So eubiotic effect, it is acting on the target bacteria, but it's not affecting your gut microbiome. So it promotes the health of gut or the good bacteria while targeting the bad bacteria. So that is the eubiotic effect with rifaximin. So rifaximin has the effect that it has on the gastrointestinal would be small bowel. You will see reduced mucosa permeability because rifaximin is more soluble bioactive in the bile-rich intestine. In the colonic mucosa and epithelial cell, you will find cytoprotective action, rendering your epithelial cells resistant to bacterial attachment or inflammatory response and apoptosis. While the effect on the gut bacteria, it preserves the colonic microbiome. It inhibits the urease production. Sorry. And it also leads to production of metabolites that protect the gut and the liver. While on the target bacteria, it alters the virulence. It causes inhibition of their adherence and decreases their toxigenicity and has an antimicrobial effect on the target bacteria. So there's a wide range of antimicrobial activity which rifaximin has over a large number of listed gram-positive, gram-negative bacteria, such as Enterococcus, Mycobacterium, Streptococcus, Enterococcus, Staph epidermidis, Staph aureus, and also Clostridium to an extent on Clostridium perfringens, difficile, Peptococcus. The gram-negative being the effect being on the E. coli, the Shigella, and Salmonella species, Proteus, bacteroids, Helicobacter pylori, Fusobacterium. So it has a broad spectrum, wide range of antimicrobial active covering a lot number of bacteria. So coming to clinical use, the gut microenvironment modulator with cytoprotective properties. So it has a role in traveler's diarrhea, in hepatic encephalopathy, cirrhosis-related complications, the inflammatory bowel syndrome, and the Crohn's disease. So role of rifaximin in cirrhosis. It reduces the overall ammonia-producing species. It improves dysbiosis of gut microbiota, reduces inflammation, reduces the oxidative stress, prevents ferroptosis properly, suppresses the translocation of gut bacteria from mouth to the intestine, and overall reduces fibrosis in a cirrhotic patient. The recommended doses are, in traveler's diarrhea, it is 200 milligram orally every 6 hours for a duration of 3 days maybe. In hepatic encephalopathy, it is given as 550 milligram orally twice daily, depending on the duration of infection, and usually given as a long-term use. And in inflammatory bowel disease, it is given as 550 milligram orally 3 times a day. to maybe 14 days. The symptoms recur, you repeat the therapy. So few of the drugs that are being used in Clostridium difficile management would be discussed today. So European Society of Clinical Microbiology and Infectious Disease 2021, they gave this update wherein they said the first episode of C. difficile infection that you have, the standard of care would be giving or administering, first choice would be fidaxomicin, given as a 200 milligram twice daily dose for 10 days. If for whatever reasons the fidaxomicin not available, cost issues, whatever it is, the second choice would be a vancomycin, which is given as 125 milligram QID for 10 days. This is standard of care. For high patients who have high risk of recurrence, the first choice again is fidaxomicin. If not available, you give standard of care, whatever drug you've chosen from first and second of the standard of care, and you add bezlotuzumab to it. And when there's non-availability of these medications, the last least preferred would be a metronidazole that is being administered. When you have this first recurrence, you give standard of care, whether a fidaxomicin or a vancomycin, and you add bezlotuzumab to it. This is first choice here. If you have given fidaxomicin as the drug of choice in the initial Clostridium difficile infection. If you preferred vancomycin for whatever reason, the next on first recurrence, the choice would be fidaxomicin. And if you have more than 2 recurrences, fecal microbiota transplantation should be done. That is the first choice. The second would be standard of care with bezlotuzumab if the patient has not received it in the past. All severe Clostridium difficile infection would warrant a vancomycin or a fidaxomicin. If oral is not available, you can give local therapies and you can give IV metronidazole or IV tigecycline. So severe complicated C. difficile infection and a refractory severe Clostridium difficile infection warrant a vancomycin or a fidaxomicin and a multidisciplinary approach with surgical consultation, intravenous tigecycline, and fecal microbiota transplantation when it is all refractory. So this is the basic lines on which you manage your Clostridium difficile infection in adults. And this slide gives an overview of pharmacodynamic and pharmacokinetics and microbiological properties when you administer your drugs that are being used in Clostridium difficile infection, the metronidazole, vancomycin, and fidaxomicin. So systemic absorption is good. It's low with vancomycin and fidaxomicin. They have higher stool concentration where it is needed. And reduction of bioactivity by feces is lower with vancomycin and fidaxomicin. Effect on diversity of microbiota, preserving your gut microbiome, the natural one, is preserved with fidaxomicin. The stool shedding decline rapidly with fidaxomicin and vancomycin. Environmental contamination is less steeper with fidaxomicin. So fidaxomicin also has a sporocidal effect and also inhibits the sporulation. So that's the advantage of using fidaxomicin as a initial therapy in Clostridium difficile infection in adults. So fidaxomicin, a few lines about it. It is a bactericidal. It kills the bacteria. It inhibits RNA synthesis, binds to the sigma subunit and of this bacterial RNA polymerase, stop transcription. And it preserves the gut microbiome. It has a narrow spectrum, means it doesn't significantly harm the beneficial gut flora and hence prevents new infection. And it stays in the gut. It has a high fecal content, achieving high local levels to fight the infection effectively. It is given as the tab form, oral form, as 200 milligram taken twice a day for 10 days. And the clinical trials have shown that fidaxomicin is non-inferior to vancomycin in achieving initial clinical cure, but is superior in reducing the rate of infection recurrence. The associated side effect could be nausea, vomiting, abdominal pain, hypersensitivity reaction. And fidaxomicin has significantly higher cost as compared to vancomycin and metronidazole. So coming to bezlotuzumab, it is a human antibody designed to bind with high affinity to C. difficile toxin B that is there in the gut lumen. So by binding to toxin B, it stops the toxin from attaching to its receptors on the intestinal cells. So this binding prevents the toxin B from being internalized into host cells, which is actually needed for it to cause damage to the cell. So by blocking the cell entry, it stops the toxin B from disrupting the cell's internal structure, preventing severe infection, inflammation, diarrhea, and colitis, which is characteristic of C. difficile infection. And in turn, it provides immediate short-term protection by delivering ready-made antibodies and do not stimulate the patient's own immune system. It targets the toxin and not the bacteria, neutralizes the toxin, doesn't really kill the bacteria or affect the gut microbiome. And it's used alongside antibiotics. It significantly lowers the rate of Clostridium difficile infection recurrence, especially in high-risk patients. With this, we come to the end of this presentation. Thank you, everyone.
Almost all the conventional drugs that we routinely use in our liver ICUs and gastro ICUs and medical ICUs. So, in fact, it was a good refresher session for me also. So, apart from, I think, the hepamers, everything else we have covered. And I don't know whether we have used fidaxomicin because I don't think it's available in India. Maybe as an import substitute, it's available, but I've not used fidaxomicin myself. So I would like your to hear about your experience on that.
No, even we have not. Even we have
Right.
not. Our initial go-to drug is still vancomycin, that oral route
Vancomycin,
that we
right,
give.
right. Yes,
Yeah.
yes.
So,
So
but
we,
then the advantage that it offers, obviously, when available and affordable, that is another thing that needs to be taken into
absolutely.
account. It definitely has a good scope, maybe.
Yeah, so we've used, like you said, we've used vancomycin oral as well as vancomycin enema also
Yes, yes.
for somebody who's not tolerating a oral thing.
Yeah, absolutely.
And so the other thing is the midodrine, as we talked about. So midodrine is something I've seen people using for intradialytic hypotension also for hypotension during dialysis sessions. Also, people have used midodrine. The conventionally people have used midodrine as a 8 hourly in a 8 hourly dosage, but like you said, the half life is around about 3 hours. So I think every 4 hour dose of midodrine should be a justified treatment option. I don't know what's the maximum dose. Maybe I think 20 or 30 milligrams is the
20 to
maximum dose
30,
for
yeah, yeah. When
yeah,
hepatologists are going up to 30.
yeah, up to 30. Right,
Yeah.
right, right, ma'am.
30
So
milligram per day is what they do practice when they do not get the desired response. They
yes,
go up on the
absolutely.
dose rate.
So I guess Dr. Tapesh is also there. If I would invite him for any expert comments if he's still there. And I don't see any questions in the chat box. So, so if you permit, we can close the session, ma'am.
Yeah, definitely. Yes, yes. Thank you so much.
Thank you so much,
Thank
and
you,
have a
everyone.
great evening. Bye bye.
Bye bye. Thank you.